Welcome back, everyone. We're going to move on to our next module here, gynecologic cancers. We're thrilled to have Dr. Mamta Chatsky from Trinity, Florida, from the Florida Cancer Specialist, who will be joining our faculty on the stage, Dr. Dave O'Malley and Dr. Brad Monk. Dave from Ohio State, Brad, the head of Phase 3 research here at the Florida Cancer Specialist. And so this is our entire faculty for the weekend, Dave and Brad. And one of the things that we're talking about is, we as a group, our theme is we want to ask a lot of questions to you all. We don't want you to necessarily tell us what we need to know. We want to ask you what we want to know. And so we put together a few videos just to remind everybody that's what we're trying to do here this weekend.
That is a really important question.
Yeah, I think it's a great question.
So that's a good question.
Excellent question.
Yeah, that's a great question.
Yeah, great questions.
Great question.
So I think it's actually a very good question.
It's a good question.
So this is a brilliant question.
What a good question.
Yeah, I think that's a great question.
That's a great question.
That is a great question.
This is a great question.
Good question.
And that's a great question.
Now what's the answer?
And, lots going on in gynecologic oncology. We have a lot to talk about here today. And actually, I was mentioning, we did two big symposia. The SGO meeting was this week. Yeah. We did two big meetings on Monday of this week. Hard to believe our entire team was out there, one on ovarian and one on endometrial. So many things. And I think, Mamta, you actually told me you watched the symposia.
Yes.
Any broad impressions about what you saw there? To me, I feel like so much is going on nowadays. What were your thoughts?
That's true. Like 10 years ago, we had only things in gynecological cancer. We are talking about platinum-based chemotherapy. And now we have HER2-based, possible immunotherapy role. That's PARP inhibitors. There's so much to talk about now compared to 10 years ago.
So we're going to kind of go through some of the data here and maybe talk about some of the clinical questions. But just to pick up a little bit more on that idea, Brad, you're running the Phase 3. What are some of the key Phase 3 questions going on right now in the field? We're going to talk about cervical cancer, uterine cancer, as well as ovarian cancer. Top line, what are some of the big trials out there that are really maybe going to change practice over the next few years?
Yeah, so I'm actually not a gynecologic oncologist, I'm an ADC doctor. and because the studies that we're doing, and HER2 is one of them, but we have TROP, CDH6, all sorts of folate receptor alpha, tissue factor. So you will see many trials coming, and there are certainly studies that are already ongoing.
Dave, any other comments? I guess one area that we're going to talk about that's really exploding is uterine cancer. We've seen some big Phase 3 trials now in the last couple of years, looking at immunotherapy. It seems to be, an area. We've seen immunotherapy also in cervical cancer. Again, we're going to get into this, but sort of top line, Dave, any comments on what we've seen in particularly metastatic disease and also the classification of uterine cancer?
So we continue to look at the molecular subclassification. We're not anywhere close to where breast and lung are. But we're continuing to identify that each individual subclassification probably needs a separate therapy. And we've been lumpers, now we're finally starting to split, which is the appropriate, more personalized, and we say the right therapy at the right time to the right patient, right? So when we look at this, what's amazing in endometrial cancer, and we're seeing this across the solid tumors, I really think we need to change the dialogue. Hazard ratios are great, median progression-free survival, median overall survival, the great talking points. Let's start talking about the opportunity to cure patients with metastatic recurrent disease. I know that's a scary word. Whatever you want to say, long-term remission, chronic disease control. We really need to be looking at it as an outcome, and so true in endometrial cancer.
That's really a great point. I've heard you make that before. Let's start talking about ovarian cancer. And again, Mamta, of course, one of the big questions in the field, and one we've had the last few years, is the primary management of ovarian cancer, particularly the use of maintenance therapy with PARP inhibitors, bevacizumab, and all the genomic issues that come up there. I'm just kind of curious, Mamta, how do you interact with gynecologic oncologists in these patients. And any questions you have before we get started kind of going through the data about that?
So I would have actually a lot of questions, but let's start from the beginning. So we do have gynecologist, oncologist in our practice, in our office, so it actually works very well. It's a direct communications and taking care of patients very efficiently on time. Especially with the BRCA and HRD positive patients, where do we stand in terms of PARP inhibitor? Are we ready to consider in the neoadjuvant setting? Adjuvant setting, if we do it, for how long would you continue the treatment?
So
Would
yeah,
you ha-
go ahead. No, go ahead.
Would you have any preference for which PARP inhibitors would you consider?
All right, so yeah, I mean, of course, that's been the question the last couple of years. Brad, maybe you can sort of provide an overview. Let's start out with the BRCA patients, and then we can get into the more challenging situations. From your point of view, is PARP, standard of care as part of maintenance therapy for a patient with BRCA or similar alterations?
Yeah, so we have two options, PARP inhibitors and bevacizumab, and then they can be combined. But they can only be combined in the HRD positive subset. And so if the patient is on bevacizumab and is not HRD, then the bevacizumab is alone. There are contraindications to bevacizumab, then we can talk about them later. In the patient that's not on bevacizumab, then it's basically a PARP for all opportunity. And niraparib and rucaparib are both NCCN recommended and ASCO recommended for an all-comer. I get it works better in BRCA, still works pretty well in HRD, but does work in HRD test negative.
So Dave, again, getting back to the BRCA patient, again, we can focus on the issue of choice of PARP inhibitor, because as we mentioned, there are three, duration of treatment, and then another question of whether to add Bev to the PARP inhibitor. Again, let's focus on BRCA, HRD deficient. Any thoughts?
Hands down, if you're not strongly recommending a PARP inhibitor for BRCA positive and not quite that strong for HRD, so BRCA wild type, HRD positive, if you're not recommending a PARP inhibitor to that patient, I would argue you're not adhering to standards of care. Which PARP inhibitor gets a more challenging question. Unfortunately, rucaparib, the company that originally owned it, was Clovis, now been picked up by our farm. But we have
Pharma and.
I apologize.
Sorry.
Thank you.
You got exabipolin on the brain. Go ahead.
Good point. So we have, when we have these opportunities, balancing the hematologic toxicity of niraparib with twice-a-day dosing of olaparib. So rucaparib's moved to the side. It's starting to come back now. As Brad said, it's NCCN guidance. So really, for me, it's niraparib with olaparib, and niraparib versus olaparib. And you'll see when I go through a few slides, I'm really a big believer in the Bev-olaparib data.
That's right. And there's a survival advantage. So this is not Monk and O'Malley thinking this up. There is a survival advantage for bevacizumab plus olaparib in HRD test positive patients, which is half of advanced ovarian cancer, and that also goes for neoadjuvant.
So before we get into the issue of the wild type patient, where of course there's a lot of contrary, just kind of curious again, Mamta, any questions about using PARP inhibitors, tolerability issues, also the issue of AML and MDS, do you bring that up to a patient? Anything you want to direct to them?
So the questions about MDS and AML, that patients that I was going to present, like patients prefer to continue olaparib beyond 2 or 3 years of duration than what we recommend. What is from your experience, if you see MDS or AML, is it usually in the first 2 years of treatment, or have you seen it beyond use of after 3, 4, 5 years of PARP inhibitor?
And Brad, can you put in perspective a little bit about the actual magnitude of risk and what we know about it in the earlier stage versus the later stage?
Yeah, so thank you for that. The risk of, as you know it because you're an AML, MDS expert, it's not just the PARP inhibitor. It's the platinums and also the duration.
Right.
So in the BRCA only, and then that patient is cured, yes, as Dr. O'Malley said, we cure patients with advanced ovarian cancer. The risk of AML, MDS is only 2 to 3%. But in that patient who gets lots of treatments and lives for a long time, it's as high as 11%. The risk of advanced ovarian cancer is also 90% death. So I think it's a balance.
What about sort of day-to-day tolerability issues, Dave? One thing we hear questions about is management of anemia. And, a simple question of, do you dose reduce or transfuse first?
That was one of the questions that came up at SGO with the group. And most of us interrupt and then reduce in transfusion to what degree of anemia. So many patients require both interruption, reduction with transfusion, particularly if they fall into the 6. We typically tend to transfuse. If I have somebody I have to transfuse, I'm going to dose reduce them. If I have somebody who's just creeping down, I'll look, interrupt, probably dose reduce without a transfusion. If I'm transfusing somebody, I am dose reducing.
And every patient on a PARP should get a multivitamin with folate and B12 just to check that box.
I was going to ask about fatigue because that was something we were also talking about at SGO. And I mean, just fatigue in general interests me in terms of the workup of a patient like that and what it's from. I hear people saying you can see fatigue with PARP inhibitors. Brad, do you see that?
Yeah, so you got 3 classes here. It's oral. And you guys know that when you give an oral anti-cancer therapy, you got nausea and diarrhea, number 1. Number 2, it's chronic because it works, fatigue. And then cytopenia because it's an anti-cancer therapy and anemia is the most common. Fatigue requires a diagnosis because the diagnosis of fatigue is multifactorial. It's dehydration, it's depression, it's sleep deprivation, it's nutritional, and it's concomitant medications. So when I see a patient that's fatigued, I try to activate this differential diagnosis, what you guys do every day. It's amazing. We think it's the con meds, and then you stop it, and she's still tired. So we really need to take a sophisticated approach to fatigue.
I feel like, Dave, have you ever talked about using Ritalin, or am I thinking of somebody else?
Oh, methylphenidate.
Sorry, methylphenidate.
Yes. You usually yell at me on that. Yeah. So, or Red Bull or caffeine or no. But when we look at, it's unbelievably consistent across solid tumors. And I don't know about the hematologic tumors with cancers. Exercise, yoga,
yes,
physical activity improves fatigue. But I just had a patient within the last. I actually saw her Thursday. She's a scrub tech, works full-time, young woman, and we tried everything, and we were debating whether or not to go back and forth, and again, I'm sorry, I'm using trade name Ritalin. We actually finally decided she would take it. She said, it changed my life, Dr. O'Malley. It changed my life. I feel like a new person. And instead of the usual 20 to 30 dose that we would do for ADD, if I have an older woman, a compromised renal function, I'll start at 5, but usually start at 10, breakfast and lunch. I don't like throwing pills at people, but in this instance, she literally said, this changed my life. I feel like a different person.
So we're going to go on now and kind of get into Dave's talk, but maybe talk a little bit more clinically because he actually has a case, and I'll be curious. Mamta, have you ever used mirvetuximab?
Yes.
What was your experience with it, and any tolerability, any ophthalmic issues?
The biggest challenge to convince the patient with all this ongoing evaluation by the ophthalmologist and going through those the eye treatments, that the eye drops, they have to use it and follow up. It was a challenge to convince the patient, but I was able to convince one patient, and she had done well.
So when she actually got treated, did she have any issues at all?
So we have like the community ophthalmologist that we have developed the relationship with them, and they're kind of now aware of it, what to look for. So I try to use the same ophthalmologist when I need it. It's not just for the gynecological oncology cancer, now that we also need the ophthalmologist quite often now. So
yeah, ADCs.
Yeah. Side effect.
All right, let's talk about some data here on Dave. You're going to go through an update here for ovarian cancer.
Yeah, there was a lot going on as we talked about, and I think with the time, I really had to get it down to some very, very pointed questions here. So this is what Brad was referring to, and Brad taught me so much during my career. One of the things that he taught me as a GYN oncologist, we used to consider ourselves surgeons who could also give chemotherapy. And what Brad has taught me and what I've seen now is we're medical oncologists who can also operate. And I'm sorry that's in this room. I hope I'm not saying anything that's completely controversial, but when we look at drug development, we look at this, these are the decisions we're making. The most important decision we make is not what type of surgery we're gonna do, is what type of therapy, chemotherapy, and maintenance therapy. And these are the first questions. Are we gonna do neoadjuvant or not neoadjuvant? Are we gonna add Bev or not add Bev? If you're not gonna use Bev, you go in the upper part, and then you're really looking at PARPs like we've already talked about in all those patients who are HRD positive and a consideration HRD negative. If you are going to use Bev, then it's continuing Bev in the HRD test negative, here I call it HRP, or are you going to use olaparib or add olaparib to it, and at times, sometimes niraparib, which is the Ovarian. But this is what we were talking about. Half of the patients, when we test for HRD, scarring within that tumor, will be HRD positive. The other half will be either negative or unknown. These are both phase 3 trials where we did this prospectively, and this is the background. It's really 50-50. Now, clearly, and this is what I was referring to, Neil, clearly, if you have an HRD positive patient, the impact on these patients is marked. And you see schematically here when we use non-PARP in each arms. This right now is versus placebo and PARP in both Paolo 1, Prima, and Athena. Paolo 1 is the Bev trial, and we'll talk more about Paolo 1. This is a paper I did with a couple of our friends as well as my junior faculty, Dr. Chambers. We really looked at if you have a low-risk patient, what do I mean by low risk? Completely resected, stage 3, not getting neoadjuvant ovarian cancer. Should we treat that patient differently? Her chance of dying from her disease is 90%. If we have a high-risk patient, what's her chance of dying from disease? 90%. How the heck do we call a patient with a chance of 90% death from her disease low risk? And here in the biggest, and again, schematically, 1 minus the hazard ratios, you see in the first and third columns, the impact is actually larger in the low risk. Again, confidence intervals overlap. This is a secondary, more of a meta-analysis. And why am I saying this? This is Philip Harder from Paolo 1. Remember, Paolo 1 is Bev versus bevilaparib. And you see on the higher risk, hazard ratio, quite impressive, 0.37. These are BRCA-only patients. But in the low risk patient, hazard ratio is 0.0, easy for me to say, right? 0.1. What curve do you want to be on? What chance do you want to get rid of that cancer so it doesn't come back? And this is PFS. And you're looking at 80% of low-risk patients haven't recurred versus 30% in the BRCA. And how about HRD positive patients? Look at those curves. Yes, we're making a huge improvement in high-risk patients, but where do you want to be on that curve on the low risk? Why are we holding our best therapies for a patient who has a 90% chance of death from her disease? And this was updated by Keta LaRusso, a good friend of ours, just at last year's ESMO, looking at survival. And this is what Brad was referring to, okay? Modest improvement in survival on the higher risk, but look at the lower risk patients. Hazard ratio, HRD positive, 0.31, 0.31, excuse me. And again, look at that curve. 5 years, 88%.
Good surgery, good chemotherapy.
Absolutely.
Good result.
I had to debate PARP versus Bev at one of our regional meetings, and I was a PARP for everybody person, so I really looked at the data objectively because they assigned me Bev. And I started thinking, you know what? I think Bev may be better in HRD negative patients. And this is looking at the group of Paolo 1 patients. Now remember, Paolo 1, bevilaparib is not indicated in HRD test negative, is not indicated. And the reason is that it made no improvement. In the rest of the world, you can get it, but not in the US. But on the right, the curve to the right is actually the Bev, and the curve to the left is olaparib Bev in the lower risk patient population. So in my mind, this added to the amount of information for me to say we are going to move forward with Bev and HRD test negative. So if everybody gets Bev If they are HRD test negative, I continue the BEV. If they're HRD positive, I add olaparib. I hope I'm curing more patients, or the medications are. I'm not doing anything.
I'll just interject too. In our way of doing consensus is we ask 20 people the same thing, and if they all say the same thing, consensus, they say 3 different things. And people have been all over the place about this subset. HRD, proficient, wild type, should you give niraparib, et cetera. But we've seen a big swift towards BEV, just exactly what you described.
And I think we're seeing a little bit, it's again, subset analysis, it's post hoc, that if you progress on PARP, you may be changing the behavior a little bit of those tumors, and the HRD, you just aren't getting enough advantage to overcome that. So this is some of the stuff we already talked to about some of the messaging on PARP and oral chemo. This is chemo that you're getting every day. We all know that now. And this is not hormonal therapy. This is chemo we're getting every day and making sure they have the right, and we can talk more about this, but you see at the bottom some of the points I made on fatigue. Now let's go to the ADCs. MIRV is now approved. We heard yesterday morning, the FDA has granted full approval, converting the accelerated approval to full approval, platinum-resistant ovarian cancer. This will be available for all of our patients, platinum-resistant. The label is 1 to 3 priors, but we use it well beyond that. Antibody-drug conjugates, we all know about them. It's against folate receptor alpha. The indication is only high. So PS2+ scoring 75% or more. All the commercial companies list out what that is. So when we really look at this trial closely, this is the phase 3. It was a 1-to-1 randomization, MIRV versus physician choice, and with a primary analysis of progression-free survival by investigator. So when we're going and looking at these arms here, you see really unprecedented improvement in platinum-resistant population. Hazard ratio of 0.65 with a modest change in progression-free survival. But look at these waterfall plots. Almost everybody is responding to the MIRV. You know, we do pretty well on chemo. So even though the overall response rate is 42%, almost all patients are benefiting by disease regression, versus 16% overall response rate and just under half, or just about half, 55% with disease regression. But what did we see really for the first time in platinum-resistant ovarian cancer? These findings translate to survival benefit. And that, in our patients, is unprecedented in platinum-resistant ovarian cancer. When we look at the toxicity associated, hematologic is higher in our chemo, peripheral neuropathy, probably a little bit similar depending on what you're using between the two. And then we see some GI. Obviously, as we talked about, the eye toxicity, 1/3 of patients will have some eye toxicity, but less than 1% of patients have had to get dose discontinued in the clinical trials. We just heard about the patient-reported outcomes with Mirasol. Guess what? If we shrink disease and keep that disease away, people feel better. Pretty amazing. We proved it with our patient-reported. Katie Moore, another good friend of ours, just reported RTXD, and you guys, and I've given up trying to say it. Brad shows off and says the whole thing. I just say RTXD. You know, we know that CDH-directed ADC, but this difference, rather than the anti-microtubulin payload, is a topo-1 payload. So much different in our payload here. We originally reported last year at ESMO with regards to the entire phase 1 trial. And when we saw that, we saw some concerns of ILD, particularly at the 8 milligram dose. So we just saw an update at SGO last week with regards to looking just at the 4.8 to 6.4 doses. And speaking of a waterfall plot, 49% overall response rate, but we see almost all except for 2 patients at disease regression. That's a pretty nice start going into a phase 3 trial. And when some of the ILD is not quite there where we thought. So it's not as high as we saw in 8, I should say. Let me be more precise. So we're moving this into phase 3. The company's given us permission to share this. It's going to be a phase 2 to a phase 3. First dose optimization, then going into a randomized trial, 1-to-1 with the optimized dose versus chemotherapy, physician's choice. Pan-Destiny. I've saved probably the more exciting here for last. I don't know if I'd say more exciting, as exciting. We're talking about it. We're across tumor types. We've heard about it. You'll hear about it today. And why are we so excited? Well, when we look at the local 2 and 3 plus and then sent off to central, we saw differentiation. Okay, so I wanted to call your attention here to the far left columns are all comers. The middle column is 3 plus, and the right column is 2 plus. And you hear endometrial, cervical, and ovary. So I met with my 7th grade daughter, right? And I said, help me figure out the 0 to 1 plus, because I have the amendment here, the addendum. I have the presentation that they gave. Help me figure out what the response rate was in 0 and 1 plus. Exactly the same as it was in 2 plus. So when we look at this, again, what the breast cancer team is teaching us is we see activity in 1 plus. NCCN lists 2 and 3 plus, and the indication, the pan-tumor that they're submitted for are 3 plus patients. Really unprecedented, very small numbers here, but very exciting. Once again, comes with expensive toxicity. Mainly what we're worried about, obviously, is the ILD, the recognition and treatment of ILD. This is not a drug like MERV where you can see some stuff on the CAT scan and ignore it. If you see stuff on CAT scan, you dose interrupt, you wait to see if it resolves, and if it doesn't resolve within 28 days, then dose reduce. Grade 2, discontinue at permanent discontinuation. So, I really am excited about where we are. Obviously, ADCs is where we're going. We still have lots of exciting opportunities, but most excited about the ADCs. Thank you.
So in a second, I'll see if Mamta has any questions, but we're getting some from the audience. One, Brad, I think very relevant from Swati here, the role of PARP inhibitors in the recurrent setting, because we've seen this FDA action. Mm-hmm. So are there situations right now where you're using PARP in the recurrent disease setting in spite of what the FDA said?
Yeah, you got to check 2 boxes. You got to be BRCA mutated, and you have to be PARP naive. It's that simple. If you're PARP treated, probably not. And if you're not BRCA, probably not.
Another question, Brad, from Dilip in the chat room. We actually got into this at SGO, the role of the Kellum score in neoadjuvant therapy. One of the thoughts was, would you use that? First of all, maybe you can explain what the Kellum score is, but one of the things we heard on Monday was using that to determine whether to use Bev or not. Deb Armstrong had brought that up, and kind of interesting idea. Can you explain what this is all about?
Kellum, Kelim, is an algorithm that looks at the decline of the CA125 in the first couple of cycles. The idea being, if the CA125 is not declining, then add bevacizumab. You can go on, they have a free website. You can enter the CA125s and look at the score. Listen, my conflict of interest is my friends call me bevacizumab, okay? And I had the opportunity to report in 2005 in New England Journal 3 times. I'm not looking for a reason to not give bevacizumab. I agree with Dr. O'Malley, my good friend. Bevacizumab is important in all tumors. And so that should be, don't deny the patient of this.
So we're going to go on now and talk about endometrial cancer and cervical cancer in a couple of minutes. Brad is going to review some of the data. We really didn't cover cervical cancer at SGO this year, but interesting there in terms of the evolution of IOs. And Dave, we've been waiting, for years now, we've been using durvalumab in non-small cell lung cancer after chemoradiation. Mm-hmm. And, the really great benefit. It looks like now it's starting to come into cervical cancer. Dave, can you talk a little bit about that?
Yeah, it's very consistent across our advanced metastatic disease that a PD-L1 or PD-1 inhibition is going to benefit our patients with or without Bev. On that particular trial, I think Leslie Randall presented that, right? We had the addition of Bev. So all patients received Bev in the advanced cervix cancer, which again is physician choice, patient choice, because in cervix cancer, you have a higher chance of fistula when we're looking at the utilization of Bev. So all patients need to be eligible for Bev. We saw, again, clear progression-free survival with a trend towards overall survival. Clearly, IO therapy in that patient population is needed.
But
Brad?
that's a first line. So
Right.
he's asking about chemotherapy
Yeah,
radiation.
Brad, you
Chemotherapy
come-
radiation should be published any day in Lancet. There'll be an editorial that we're proud of in Lancet. When added to chemotherapy and radiation and continued in maintenance, pembrolizumab, not Bev, pembrolizumab has a survival advantage based on a press release that was just last Friday, a week ago yesterday, okay? And it's FDA approved since January 12th, but only for high-risk patients. In other words, chemotherapy and radiation is probably sufficient to cure the patient that does not have pelvic sidewall disease, does not have ureteral obstruction, and does not have bowel or bladder invasion. And that is the indication. And on February 23rd, the NCCN guidelines were also updated without the publication, which is unprecedented. And now it's FDA approved, NCCN recommended, and has a survival advantage based on this press release. Chemotherapy, radiation, pembrolizumab continued in maintenance for 2 years, okay? And only for ureteral, sidewall, bladder, and rectal involvement.
And Mamta, I'm going to guess you've probably given durvalumab post-chemo radiation and lung cancer a few times. How often do you see, as a medical oncologist, cervical cancer? Have you seen patients in these situations?
This is very exciting that the news and data came out. We have done platinum-based chemotherapy with radiations for all these years, since that I have been working in this field. So this is the first time ever we have this data that I'm very looking forward to use this in my patient population when it's the right setting.
Have you done it for non-small cell with durvalumab?
Yes, I have done it.
And, from this, of course, that's been going on for years now, and they saw great prolonged advance.
right.
Nobody knows how much it may be related to radiation and the IO interacting.
Yeah.
Again, let's do a little, before Brad gets into the data, kind of a little bit more discussion in terms of endometrial cancer. In a second, I'll ask Mamta if she has any questions coming out of this wild program we did on Monday with Shannon Weston there. And Dave, I guess one thing, maybe you could talk a little bit about how you view subsets within endometrial cancer. On Monday we were talking about POLE, which you're the only cancer we even talk about that in, but also, of course, obviously MSI high, et cetera. Dave, can you comment on that?
Yeah, MMR, the first division, MMR deficient or proficient or MSI high. Next division, if you're proficient, you're looking at, are you P53 mutated or not mutated? We call those NSMBP, non-specific molecular profile. That name drives me nuts. I call them P53 wild type. So when we really look at this, the POLE mutations are less than 2% of patients. So we look for it, and there are some histological features which make us more suspicious, but it's a very small group of patients. Those POLE patients do markedly better
But
than
they're
all others.
super hypermutated, more than MSI high.
Correct. They're above MSI high, and because of that,
And the TMB is even higher, right?
it's off the ceiling, over the ceiling.
And those are seen in CRC as well.
Sure, of course.
Okay, of course.
Right.
And so it's the same thing in colorectal
Well,
cancer.
do they see POLE and CRC?
That's what I'm saying,
Oh,
yes.
really?
Yeah.
Huh. I never heard that. That's really interesting. Can you talk a little bit, too? This is a great diagram that Brad pulled up. But one of the things that kind of came out this time at SGO that I wasn't aware of, I think some of it because it was new data, and Mamta, you were commenting to me also, was what you have down here, P53. Mm-hmm. And, we heard them talking about maybe the P53 mutants respond better to IOs, like MSI high, but then also selinexor and PM wild type. Did you pick up on that, Mamta? In the symposium?
Yeah, I did. That was something interesting that we never heard of this in the uterine cancer, and now we have used it and familiar with it in the multiple myeloma, and now we have data for the uterine cancer. And maybe you can comment more on the patients with the TP53 mutations. What is their response, and where do you recommend for community oncologists? Where does it stand right now?
Yeah, and there's selinexor that Brad just put up. Look at over there on the right, wild type versus not. So, Dave?
So I was just going to say, the challenging right now is make sure you get the information. And your pathologists start doing. I'm at an NCCN, NCI designated cancer center, and we just finalized our algorithms to make sure I get this information. where we've been doing MMRD for a decade, but now also then getting that P53 and POLE, we still don't have a as consistent of a workflow for POLE. So unless the pathologist tell me, hey, I'm suspicious it's POLE, this hypermutated appearance, the glandular appearance, then we're not sending this consistently. So getting that information is so important because, though it's a unplanned subset analysis, we saw in Ruby, we're still waiting to see the GYN 18 data, that it did appear that the benefit in the P53 mutated group in Ruby, which Brad will talk about, was provided benefit. And so when the patients sit in front of us and we have these decisions to make, we have a clinical trial that's open, P53 mutated versus P53 wild type, if I don't have that information, I can't drive down to that molecular subtype.
So POLE is the only one that requires next-gen sequencing. You can do the 4 standard biomarkers with IHC, which would include just what you said, my friend, mismatch repair deficiency. P53 can be measured very accurately with IHC, ERPR, and HER. So the sequencing for POLE is important, but it's rare. But you can do 4 things. And every patient that you see with ovarian, you got to say whether she's HRD or folate receptor alpha, yes. And every patient with endometrial cancer, MMR, P53, ERPR, HER.
So we're going to let Brad start at the beginning of his talk. But again, just to kind of go back to Dave again, sort of putting in perspective kind of what we've been learning, particularly over the last couple of years in terms of endometrial cancer, just from a more macro perspective, Dave, how are we, from your point of view, how are we currently approaching first-line therapy, metastatic endometrial cancer, MS stable, MSI high, let's put POLE to the side, but just MS stable, MSI, how are you thinking it through?
What I said about PARPs, if you're not using PARPs and BRCA, you're not adhering to the standard of care. If you're not using IO with carboplatin paclitaxel and MMR deficient, you're not adhering to the standards of care. Drop the mic, period, end of story. The proficient...
How about if I say, what do you really need the chemo?
That's a great question. I love it. So one of my pet peeves is when I'm interviewing fellows and residents, they go, that's a great question. I wouldn't freaking asked it if it wasn't a great question, right? So that's so funny. I just did that to Neil. So...
Can't help it.
You know, so we have a trial which has completed enrollment, one within GOG, that we're looking at answering that question. Carboplatin paclitaxel, the combination is very, very good. It is... I think it's probably going to be a negative trial. If you had a patient who said, I refuse chemo, that's a conversation to have. Single agent IO. We know that the response rate from my Keynote 158, as fortunate enough to lead a JCO paper, 50% response rate. 50% response rate. Of those that respond, this is the recurrent setting, about 2/3 will get long-term disease control. Or maybe cured.
MS stable?
MS deficient.
No, I'm saying, what do you do for MS stable?
MS stable right now, I have the conversation with the patient. P53 mutated, I tend to use either dostarlimab or Pembro, okay, with carboplatin paclitaxel.
Frontline.
In the frontline setting, okay? But we have a conversation with regards to molecular subtyping because there's some patients that balancing the risk versus the benefit becomes a challenge, and we have a clinical trial that probably will answer that question moving forward. So something I talk about with every single patient who is proficient in the upfront setting. In the recurrent setting, lenvatinib Pembro, not single agent Pembro in the recurrent setting.
For PMMR.
For PMMR.
All right, Brad, let's take a look at your slides.
Yeah, so this is the typical scenario. And the problem with the de-escalation strategy is the chemo, the control arm is wrong now. He said the control arm should be triplet therapy, carboplatin paclitaxel, pembrolizumab, or dostarlimab, but we're comparing it versus chemo like you guys did in CRC. So that trial will be uninformative because the control arm is wrong. But this is what we're seeing. Most of our patients in the second line are still checkpoint naive because the approval was just last July. So Mamta, how would you handle this? So here you have an MSI high patient, okay? Dr. O'Malley wrote this beautiful paper in the JCO, 50% response rate. but she's her IH3 plus. How do you make that decision?
Well, personally, I would intend to try to use the TDXT in this situation with that HER2 positive, but
she's MSI high, though.
MSI high.
And she never had an IO?
Right.
Did she or did she not?
No, she never had an IO.
Right.
Then I would rather go with the IO and
How
then
about
keep
both?
that in the mind.
So I like both. And the tolerability has been answered. So that's, but I would never sort of think that we had a sequencing issue. So here is the NCCN guidelines. IO is everywhere. It's in the front line, what you said, Dave. Okay, in the DMMR MSI, FDA approved. But even in the front line, non-MSI, it's NCCN recommended. Okay, and in the second line, if you're checkpoint naive, just what you said, MSI high, what you said, let's use checkpoint. And if she's not, then let's add lenvatinib. Now this will change. This will change because Ruby presented at the SGO showed in the PMMR subset, non-MSI, frontline, 7-month improvement in overall survival. Okay? But Merck is ahead. And so Merck is actually filed in the PMMR subset and the DMMR. So we only have DMMR dostarlimab today, but now the action date is June 21st. So before or on June 21st, we will have an all-comer indication likely, okay, in the front line.
I guess, that's the only reason that's important is because one of the things, at least I think a lot of people thought about initially is, do you really need to give it first line or can you just hold off and give lenvatinib and Pembro second line if in the long run they're going to be just as good? But if you've got survival data using it first line, I think that answers the question.
So I want to mention one thing in maybe a few minutes on cervical. So this idea that maybe you can add PARP inhibitors to the triplet chemotherapy, checkpoint in the non-MSI PMMR, quite frankly, where checkpoints don't work very well. And we don't have time to go through a lot of slides, but you can sort of see the incremental benefit, okay? Control chemotherapy, and then chemotherapy durva, and then the PARP inhibitor. Let me talk hazard ratio. So PMMR dostarlimab is 7.6. You can add dostarlimab and niraparib, you get to 0.63. 7.6 to 0.63, yeah. But with durvalumab olaparib, you get to 0.55. And Neil, this has also been filed to the FDA, okay? In the quadruplet PMMR frontline setting, and it's also been filed to the CHMP.
Yeah, we've been hearing about this idea combining IO and PARP for a while. They've been trying it. It kind of didn't look too exciting. Again, Shannon Weston was running the program for us on Monday, and she was the PI on it, and she's ready to go to use this strategy.
Yes. So, before we transition to cervical cancer, I want to explain what the GOG Foundation is. I think there's a lot of misunderstanding. It's a nonprofit foundation, and it runs energy trials, but Dave and I work for GOG Partners. We don't work for them. We work for Florida Cancer and Ohio State. But we do these trials, all of these trials. And Sarah Cannon Research Institute is part of the GOG Foundation, which is what many of us do. And so the GOG Foundation designs the right trials with sponsors, works with you through Sarah Cannon Research Institute to do them, and then performs educational opportunities like this. So it is in scope and on point to get these trials done. So we've made a lot of progress in phase 3 trials in cervical cancer, and so when I see a patient, first question, is she eligible for a clinical trial? Second question, if it's a cervical cancer, is she eligible for an anti-angiogenic? Is she eligible for IO, or is she eligible for an ADC? You just ask that question. First question, eligible for a clinical trial, okay? So we are moving ahead, and I know we're short on time. We're moving ahead in what we call the first line setting, which does not include chemotherapy and radiation. So chemotherapy and radiation does not count as a line of therapy. So you got chemotherapy, you got Bev, and now you have the quadruplet. And look what you get here. you get a 69% response rate, you get a median survival of 29 months, and then after that, you do an ADC. It's not that complicated, okay? And the ADC is an all-comer. We like trastuzumab deruxtecan, but it is only generally in the 2+ or 3+, which is a rare subset. And then finally, let's see if we have, finally, this is delayed. Finally, I just want to show you the curve for the FDA approval for A18 with chemotherapy and radiation, in ureteral involvement, sidewall, bladder, and rectal. This is what you get, approved, as you know, January 12th, now NCCN recommended, and now survival advantage best on a press release. So what you do, late phase development, terminal patients, earlier lines, combinations, other tumor types. And that's sort of the paradigm for changing the standard of care through the research program that you guys participate in. Thank you.
So I want to go back to a couple things we talked about before and pick up a little bit on it and get your take on it. One is HER2-positive disease, and you showed the impressive results there in all three of these cancers. One of the issues I think that comes up, and Dave, I chatted with you about this, is HER2 testing. And you put up some slides showing 1+ and 2+, and the general oncologists out there are saying, well, where's the fish? Because in breast cancer, we're used to doing reflex FISH. And so from that perspective, we can't.
FISH is not a part of G1.
So you guys don't have that. So Dave, can you talk a little bit about how you're approaching HER2 testing and particularly how you're interpreting it?
So we don't have a standard way to read in GYN cancers. We don't have a validated. As you know, by Pandestiny, they used the gastric criteria. So now when I send to my pathologist, I send that request for HER2, I say use the gastric criteria. Yes. Previously, we used a modified breast. And we had 2+, then we would reflex to FISH. Yes. So they still are doing that, and then they read HER2 negative. And you go, no, I don't want to know. I want to know, is it 1+, 2+, or 3+?
But the discordance in Pandestiny tumor for local, not Ohio State, and central testing is 40%. So you got to be careful, not only who's doing it, but how they're doing it. And Pandestiny 2, FISH was not a part of it.
Can we also talk about the use of TDXD? And again, Mamta, I'm guessing you've used TDXD in breast cancer?
Yes, I have.
I'm curious what your experience is in terms of tolerability. Actually, it's interesting because the general oncologists have much more experience. We see TDXD coming into GYN, GI, pulmonary, et cetera. What's been your experience, particularly in terms of acute issues, in terms of nausea and vomiting? How are you screening for ILD?
So patients have tolerated quite well with minimal nausea and vomiting. In my experience, my patient did have grade 1 ILD. I had to hold the treatment and temporarily treated the patient, and she was actually re-challenged with it, with the reduced dose.
And did she actually respond?
She just had responded.
So Dave, any experiences you've had with TDXD, both positive in terms of people responding and also side effect issues or ILD?
So I saw a patient this week, cycle 24. We really look at this, it's about 9 months, your duration of response, maybe not quite that. But, when we look at this, when they get response, we get very good sustained disease. I haven't seen a patient like the case I used of 4 years, like Merv, but, I'm hoping to one day to see that. So what's interesting is I've talked to my specialty pharmacist for the last few years. Every time I got a CAT scan in the chest with Merv and it had some ground glass opacities, I said, don't worry about it. We saw these patients on clinical trial. They're fine. Treat through. We're good. That's with Merv. No. Now with TDXD. Every one of these trials, from breast to now Pandestiny, but, a couple patients have been killed. So let's be very, very, make sure that our nursing team knows, our APPs know, and that we identify. And I start at cycle 1 and then educate every cycle with the patient. Subtle cough, shortness of breath, and then we get pulse ox and everybody come in. What's interesting on the GI, the delay in the GI, especially the diarrhea and some of the nausea, I'm seeing it more at like day 7, 10, rather than what I'm typically used to in that day 3 to 4. So it's interesting. It seems like the GI side effects are a little bit later in the course than our classic cytotoxic chemotherapy. Again, educating patients, make sure you call us and intervene, make sure they have the interventions at home, and then if it's depending on when they're getting infused, it's going to happen over the weekend, making sure we have support for them.
I haven't heard about delayed nausea. Have you seen it, Mamta?
The patient that I actually have treated, she has been having an ongoing nausea, vomiting, so it's very hard to differentiate like the chemotherapy related. But I personally have not noticed like delayed as Dr.
So
Omani.
TDXD is MEC, moderate emetogenic chemotherapy. I treat it as HEC for this, just what you said. So I use triplet antiemetic therapy, and as the NCCN would recommend, with HEC, highly emetogenic chemotherapy.
So we're going to move on now and talk about breast cancer. Thanks so much for joining us today.
Thank you.